Hi, I'm glad you've joined us today for Demystifying MS-DRGs, learning about MS-DRGs and how they are assigned. My name is Casto, and I'm a volunteer with OHIMA, and we're ready to dive in today to this interesting topic. So today we'll learn about the Medicare-Severity diagnosis-related groups. We'll walk through the structure of the classification system, and then we'll talk about the process of assigning MS-DRGs to an acute care inpatient setting. Understanding how MS-DRGs are assigned in the acute care inpatient admission setting is important for coding professionals, coding managers, and revenue cycle professionals. It's really important to be able to explain the logic behind the assignments because this will help you communicate documentation and coding needs to providers and clinicians. Okay, so the classification system itself is called Medicare-Severity diagnosis-related groups, or folks in the hospital call them MS-DRGs, or often you'll also hear just DRGs. That was the original classification system. The Medicare-Severity was added in 2008 to add that severity component to the payment system that utilizes this classification system. So this system organizes inpatient admissions into large groups for reimbursement purposes. So the groups contain admissions with that are clinically similar with like resource consumption into a manageable number of groups. And this facilitates analysis of inpatient admissions, reimbursement of inpatient admissions, and also research in this area. The system takes into consideration the role that a hospital's composition of patients play on influencing cost. So we like to say resource intensity, and we'll say, what's the resource intensity of the admission or of the MS-DRG group itself? And what we're doing is we're measuring the resources required to treat a patient that have similar clinical conditions and perhaps surgical needs. So this structure is hierarchical in design. The highest level is the major diagnostic category, or the MDC. And we're going to use that term throughout this presentation because that plays a key role in assigning the correct MS-DRG. So MDCs represent body systems treated by medicine. Think of diseases of the musculoskeletal system or infectious disease. So we think, they kind of line up with the different chapters in your ICD-10 CM codebook. The next level is surgical or medical. Did the case have a surgery, a significant surgery or not? And the third and final level are the individual MS-DRGs. So we're going to talk about how we get from the MDC, or this big body system, all the way down to the individual DRG assigned to the admission. There are 4 steps in the assignment process, and I have them listed here for you on the left side of the screen. Pre-MDC assignment, MDC determination, medical or surgical determination, and then refinement. Okay. Hospitals, payers, researchers, they all use the MS-DRG grouper, which is software designed to assign cases to MS-DRGs. And if you work in an acute care setting in the hospital, you will most likely have access to the grouper. However, it's really important for HIM professionals to understand the algorithms that are built into the grouper. We have to be proficient with these steps of assignment in order to help others understand why certain admissions are assigned to particular MS-DRGs. And I have this in here because this is real world. When I was the assistant director at OSU Medical Center, I had physician leaders come to me and have me explain to them why cases were grouping one way or another. So a valid answer isn't because that's what the grouper does, right? We have to be able to say, this is why this admission was assigned to this particular MS-DRG. Okay, so let's start in on the steps. Step one, pre-MDC assignments. Okay, most MS-DRG assignments begin with assessing the principal diagnosis or a combination of the principal diagnosis and a procedure. However, step one is dedicated to specific procedures that are used to determine the MS-DRG assignment rather than the principal diagnosis or a combination of the principal diagnosis and procedure. The list of qualifying procedures for pre-MDC assignment include those that are very costly and can be performed for a variety of diagnoses. So let's take a look at an example. We're going to use MS-DRG 10 pancreas transplant. So if we think about a pancreas transplant, it can be performed for a variety of clinical conditions. And I have, some of them listed here on the left side of this slide. Diabetes with renal, ophthalmic, neurological, or peripheral circulatory manifestations. When a patient has diabetes, that goes to MDC 10. A transplant can be performed for a patient with hypertensive renal disease. That's an MDC 5, diseases and disorders of the circulatory system. Perhaps the patient has chronic pancreatitis. That's an MDC 6 in the digestive system. Chronic renal failure. That could be a valid reason for a pancreas transplant, and that's an MDC 11, diseases and disorders of the kidney and urinary tract. Or we can have complication of transplanted organs. Perhaps this is the second transplant for this patient because the first one failed. Okay? So you can see there are a variety of MDCs, clinical reasons why a patient can have a pancreas transplant. So Medicare did not assign an MS-DRG for each of these clinical areas. If we use the regular MS-DRG structure, we would be left with 5 different groupings for a pancreas transplant. And these groupings would have very little volume. And the driver, I should say, for the cost or the resource intensity of the pancreas transplant is the transplant itself, not the diabetes, the renal disease, the pancreatitis, those things. It's the transplant itself. So in order to have a manageable number of MS-DRGs and really adhere to the concept of resource consumptions groupings, we have one MS-DRG, regardless of why it's being performed. So we only have a handful of DRGs in this area. So just a small number of cases will apply in this step one. Okay. And once you perform step one, once the case is assigned, let's say to MS-DRG 10, the process is over. We skip the remaining 3 steps. We just have step one for these cases. Okay, so if we don't have a pre-MDC procedure, and we move to step 2, which is MDC assignment. Now, the principal diagnosis is used to place the admission in one of the 25 MDCs. And just as a reminder, the principal diagnosis is the reason established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. So it's why really the patient had to go to the hospital for an acute care inpatient admission. Not necessarily the signs and symptoms, but the definitive diagnosis. Let's take a look here at code C41.3, malignant neoplasm of the ribs, okay? Sternum and clavicle. It is mapped to MDC 8, diseases and disorders of the musculoskeletal system and connective tissue. Okay? So we may say, well, how do we know where each of the diagnosis codes that's included in the ICD-10 CM codebook are assigned, which MDC are they assigned to, and can they be assigned to multiple? So we use Appendix B of the MS-DRG Definitions Manual, which provides the linkage between the diagnosis code and the corresponding MDC. Okay. So I have a link there for you where you can get to the MS-DRG definitions manual, but really that's going to be our key resource all the way through this presentation. We're going to go back again and again to help us understand why admissions go to a certain MS-DRG. Okay, so now we know the MDC. Let's move on to medical and surgical determination. In this step, procedures performed during the admission are assessed to determine if an operating room OR procedure was performed. Okay. Medicare still uses this term OR procedure. Originally, most of the procedures that were deemed surgical were procedures that were performed in the OR. However, there are some procedures not performed in the OR, but that have the power of an OR procedure and do influence the MS-DRG assignment, and specifically impact the movement towards a surgical MS-DRG. So a really good example of that is a stem cell or bone marrow transplants. They're considered OR procedures due to their significance in the admission and their associated costs. So a bone marrow transplant, a stem cell transplant is an infusion. It's done in an infusion room. It's not done in the OR, but the cost associated with that is really expensive. So again, this system is based on resource consumption as the driver. So we have some of these procedures included in the surgical branch of this classification system. Again, we're going to go to Appendix E of the MS-DRG Definitions Manual, which provides a list of the OR procedures. And I want to explain this a little bit here. You have an excerpt from that Appendix E on the right side of your slide. And particularly in this presentation, we're going to use the example of procedure code 0YHC43Z, which is insertion of an infusion device into the right upper leg, percutaneous endoscopic approach. Now, this is a non-OR procedure, but it's going to drive MS-DRG assignment because in this system, it's classified as surgical. Okay. So when we look at the excerpt of Appendix E, procedure codes without an asterisk are considered an OR procedure. So if we look at the first one on this list, 0YHB31Z, that's a surgical procedure, doesn't have an asterisk. But if we take a look at other ones, the procedure codes with an asterisk are non-OR procedures, not done in the operating room, but in the system, they still impact the MS-DRG assignment. So they're called OR procedures. And these are exceptions to the common belief that only OR procedures, or I should say the common myth that only OR procedures impact MS-DRG assignment. So again, you want to go to Appendix E. If you have questions about this step from surgeons or physicians, they may say, I didn't take my patient to the OR. Why is my MS-DRG a surgical DRG for this admission? And here's where you can take your physician and show them how this classification system really takes resource-intensive procedures, even though they're not performed in the OR, but uses them to impact MS-DRG assignment. Okay, that was a lot, but let's move on here to an example, okay? And some procedures, we're going to mention this first. Some procedures can group to several MS-DRGs. And the determining factor of which group of MS-DRGs we're going to consider is the principal diagnosis. So we remember back to step 2, the principal diagnosis determines the MDC. So I have an example here of procedure 03LG3BZ. This procedure code maps to many different MS-DRG families or sets. And you can see that here on the lower part of this slide. It could be MDC 1, it could be MDC 5, 11, 21, or 24. So really what determines which of these buckets or which of these MS-DRG families we're going to consider in the next step is that principal diagnosis MDC match. Okay. So in this example, occlusion of the intracranial artery with a bioactive intraluminal device using percutaneous approach can go into any 5 of these MDCs. Okay. And all of those are surgical MS-DRG families. Okay. All right. Note 2, the procedure does not have to be the principal procedure to influence the MS-DRG assignment. The OR procedure can be in any of the ICD-10 PCS code slots on the claim form. So again, we're busting another myth here that the procedure that impacts the MS-DRG assignment has to be the principal procedure. That's just not true. It can be in any of the slots on the claim form. So hospitals use the CMS 1450. You may have heard of it as the UB04 claim form. And again, MS-DRGs apply to inpatient acute care settings. So this is the form that is used. Claim form locator 74 is reserved for the principal procedure, followed by A for E for other procedures. Now, the electronic version of the claim form includes space for up to 10 procedure codes. So any one of those 10 can be the surgical procedure that impacts the MS-DRG assignment. Okay. Now we know which MDC our case is assigned to. We know if it's medical or surgical. And now we move into step 4 for refinement, excuse me. There's can be a variety of refinement questions for an MS-DRG base set or an MS-DRG family. The most common refinement questions relate to the presence of a CC or MCC secondary diagnosis. Okay, so the majority of our MS-DRG base sets are divided into individual DRGs based on the severity of illness for the admission. And this classification system uses the CCs and the MCC secondary diagnosis codes to assign the severity of illness level. Okay, this is different than APR DRGs. This is how it's done in MS-DRGs. Okay, so I think the best way to examine MS-DRG refinement questions is to look at some of the base sets. And here's an example for you on the left. This base DRG extracranial procedures is divided into 3 severity levels. And our lowest severity level is MS-DRGs 39. It's extracranial procedures without CC MCC. So our first refinement question is there an MCC secondary diagnosis? And if the answer is yes, then the case is assigned to MS-DRG 37. And then the process stops. We've assigned our MS-DRG. If there isn't an MCC, then we move to our next question. Is there a CC secondary diagnosis? If the answer is yes, then we assign MS-DRG 38 extracranial procedures with CC, and then the process is complete. If there's neither an MCC or a CC secondary diagnosis, then we assign MS-DRG 39, and that's our lowest level of severity of illness. Now we're going to go through a couple more examples because it's not always that simple. Sometimes our base DRGs have other refinement questions that we need to take a look at. So let's say our admission is for a patient that had an acute myocardial infarction and a CC as a secondary diagnosis. The procedures performed were a cardiac catheterization and a cardiac defibrillator implant. Okay. So for our first refinement question was there a cardiac cath? So when we look at this base group of MS-DRGs 222 through 227, all of them had a cardiac defibrillator implant, right? So our first question is, was there a cardiac cath? Okay. And you can see we have 4 MS-DRGs that have with cardiac catheterization and 2 without. So answering this question narrows our choices from 6 to 4. And in our example, the answer is yes. So we move to consider MS-DRGs 222 through 225. Okay. The second refinement question, did a patient have acute myocardial infarction, heart failure, or shock? Okay. And the answer is yes. Our patient had acute myocardial infarction or a heart attack. And so we can narrow our MS-DRG choices down again to 222 to 223, right? The first 2 in the table at the top of the slide, because our patient did have a heart attack. And then our last refinement question is, did the patient have an MCC? Earlier, I mentioned that no, our patient just had a CC, they didn't have an MCC. So our final MS-DRG assignment is 223, cardiac defibrillator implant with cardiac catheterization, with AMI, heart failure, or shock without MCC. Okay? So I think this is a really good illustration of how you would walk through an MS-DRG set or MS-DRG family and determine which one is applicable through these refinement questions. Okay, let's do another one. Here we have the base set for appendectomies. And again, we have 6 MS-DRGs that would be possible. Okay. And this one can be kind of tricky. Okay. So when we look at this, the first question, is there a complicated principal diagnosis? And here we have to go back to that MS-DRG definitions manual to identify which diagnosis codes are considered complicated. Because, complicated for appendectomy isn't complicated necessarily for another procedure. So we go back and we look in the MS-DRG definitions manual. And here we can see listed the 5 diagnosis codes that are considered complicated for this MS-DRG. Okay. And then our second question is there an MCC diagnosis? And then our third is there a CC diagnosis? So let's say for this base set, our admission is for an appendectomy, and the patient's principal diagnosis is K35.21, acute appendicitis with generalized peritonitis with abscess. Okay, so you can see from the excerpt from the MS-DRG definitions manual that K35.21 is a complicated diagnosis. So we're going to go from 6 DRGs to 3 MS-DRGs. So now we can consider 338 through 340 because we know we have a complicated principal diagnosis. Okay. And then our patient has, let's say our patient has both a MCC and CC. In this case, the MCC overrules the CC and the admission is assigned to MS-DRG 338. Because the MCC has a higher severity of level, it's that extensive severity of illness, than the CC, which is just a moderate severity of illness. So our final MS-DRG is 338 in this example. All right. Huge success. Following these 4 steps leads to the final MS-DRG assignment. But wait, as in many things within Medicare and reimbursement and coding, there is one caveat. There's always one exception, right? We have to consider the CC-MCC exclusion list. Okay. At some point, a physician, a clinician is going to ask you why an admission is not grouping to a CC, MCC, MS-DRG when there's a CC or MCC condition listed as a secondary diagnosis on the claim. They're like, I can see there's an MCC on this admission. Why am I not going to the highest severity of illness, MS-DRG? That's what they're going to ask you. And most likely the answer relates to the exclusion list. When a CC or MCC, a diagnosis code, is closely related to the principal diagnosis, it's placed on the exclusion list. And that's because the resources involved in treating that principal diagnosis and our secondary code are kind of all together. So the resources for treating something non-related are kind of added on. You have more resources. These is kind of all together. So we have this exclusion list. And this takes away the power of the CC or MCC code that would typically allow the case to be assigned to a higher weighted, higher severity of illness, MS-DRG. And as always, you're saying, how do I know what's on an exclusion list? And the answer, again, is in the MS-DRG Definitions Manual, Appendix C. There, you'll have a listing of what's included in a in the exclusion list. So let's take code M31.11, hematopoietic stem cell transplantation associated thrombotic microangiopathy. And this code is an MCC. And for exclusions, it's assigned to Principal Diagnosis Collection 4463. So let's examine an admission where the principal diagnosis is type 1 diabetes mellitus with diabetic peripheral angiopathy with gangrene. So that's E10.52. And code M31.11 is a secondary diagnosis code. So here we can see, since they're in this principal diagnosis collection, the power of M31.11 as an MCC is taken away. And this case would then group to an MS-DRG without an MCC. So by examining the principal diagnosis collection sets and looking for the codes that are included on your claim or that have been coded by the coders, you can see if that exclusion applies or doesn't apply. Okay. And this is, again, this Appendix C is a good resource for when you're talking with other clinicians, members of the revenue cycle team, even compliance. So let's bring it all together in an example. We have a patient who's a 67-year-old woman with type 1 diabetes mellitus. She was admitted for the treatment of a grade 3 foot ulcer, which involved necrosis of the muscle on the right foot with gangrene changes resulting from diabetic neuropathy, atherosclerosis, and chronic peripheral vascular insufficiency. Excisional debridement of the ulcer was performed to the muscle, all the way down to the muscle. Okay, so on the right side of this slide, you can see the principal diagnosis, our secondary diagnoses, and the principal procedure. So our atherosclerosis native artery with gangrene is a CC. That's I-70.261. Our diabetic foot ulcer is not a CC or MCC, nor is our non-pressure chronic ulcer. Okay. And likewise, our third diabetic code to represent the diabetic neuropathy is not a CC or MCC either. So on this case, we have one CC. Okay, so our pre-MDC assignment, step 1, excisional debridement is not on the approved list for pre-MDC assignment. So we're going to move to step 2. MDC assignment. Our principal diagnosis is E10.52, and we can see that that groups to MDC 5. Okay, because we know our procedure is not a pre, so we go right to MDC 5. Our medical surgical assignment. Our procedure code was an excisional debridement That's 0KB W0ZZ. And this procedure is not in Appendix E, listing of OR procedures. Therefore, this case is labeled as medical. Okay? Even though they did the excisional debridement, it's not a huge resource-intensive procedure. It's not done necessarily in the OR when it's done by itself. So this is a medical case. And then we move to step 4, refinement. Okay, so in step 2, we know that our applicable MS-DRG base set is MS-DRGs 299 through 301. And there are 2 refinement questions. Is there an MCC? Nope, not in this case. Is there a CC? Yes, there is, but let's check the exclusions. So the principal diagnosis collection is 519, and code E10.52 is not included, so no exclusion applies. So we have here our 3 choices, and we have a CC. So we are going to have the final MS-DRG assignment is MS-DRG 300, peripheral vascular disorders with CC. So that's how we bring all the steps together to get our final assignment. So let's talk a little bit about careers. You know, there are a lot of careers available for individuals who've studied coding and reimbursement and revenue cycle. And I'm going to kind of focus here on the second column in this graphic where we have coding analyst, coding auditor, denial coding analyst, and quality assurance coder. All those positions really do require someone that has an in-depth understanding of inpatient reimbursement systems. For Medicare, it's IPPS, which uses the MS-DRG classification system. But also a lot of commercial payers take the foundation of that MS-DRG classification system and use it in their own inpatient payment systems. So really having this good foundational knowledge about how MS-DRG assigns really will make you a better coding professional and a better coding analytics profession. Okay. So there's lots of health information careers in the revenue cycle. And if you want to learn more, OHIMA has developed a revenue cycle hub for you to easily access informational videos, including today's video, as well as article, careers, certifications, and education related to the revenue cycle. If you are interested in exploring a career in the revenue cycle or simply would like to learn more, please scan the QR code on the screen or visit ohima.org/revenue cycle. All of OHIMA's information videos will be available under the resources tab. Really, what a great service OHIMA is providing to all its members, where you can get a great career information. I want to thank you for joining me today. I hope you found this presentation helpful. I've included my email if you have any further questions or comments. Again, thank you for joining me today and have a great day.